You just put your feet down on the floor, because the chances are that when you say to most patients, okay, I want you to tighten these muscles here, what they'll do is they'll straighten the knees, and you don't want any action with the knees at all. So putting them up on the chair like this seems to stop that. Now we'll just go up a little bit. Okay, we'll just get the posterior superior iliac spine over the table like this. All right, now I can just come around here, get onto the sacrum here. My other hand can hold on the core, the cephalic bone. Now, and can you just gently hold there? Now relax. Now let your knees go down to the ground. So now I can use the weight of the legs. Can you just hold again? And relax and down, and I can get a very specific action by letting her use her legs. Now, can you just put your legs down, and then I want you to go back in the same position. Don't just change it for a second. Another very useful piece of equipment, say I didn't bring it, is the wedge. And what I can do with the wedge is to place the wedge on that transverse processes of the cephalic bones. Can you put your legs up now, please? And then just sort of hold there, just and relax, and then going down here. So it spreads the load out over several areas. So this is quite useful. But your hand on here is perfectly okay. And just come up now. Just think just where the edge of this wedge is. Can you just sort of hold where the edge? Oh, look at that. Perfect. Now relax. Now, I don't think my dog could do that. Just up again, just one level. But she's doing that just at that one level and down. And this knowledge, you know, it's really quite interesting. People that, I mean, Anne's obviously trained in kinesiology, but even patients with the correct sensations, this was a good thing about PNF, wasn't it? They would do what you wanted if you gave the impetus in the right direction. Now, just come up again, and there. And now let yourself go down. Your legs go down. Knees to the floor. Let it bend. Not take them off, just pulling them under the table. So we try and enact some flexion movements. Now, just stop me pushing you down in that direction, just where the edge of this thing is. Very good. Now relax, now down again. And so we can stretch, and now I can put a little bit of a good stretch on that particular point. So there are 3 techniques to start with. Then I'm going to show you another very elegant procedure, but we'll just do these first. So we've got, thanks Anne, the side lying first of all. Then we've got the prone lying over the table, and then going to the end of the table for a more complete stretch.
At the end of the table, was she actively pulling her knees in?
Yes, when I asked her to, but to start with, it was purely that the weight of the legs and the pelvis were just pulling down.
So you wanted her to bring her knees towards the head of the bed?
Yes, yeah, to tuck them underneath the bed. Now, obviously, this is going to be less effective the higher we get, because there's a lot more to control there. But on the whole, when we think about where the maximum lordosis is, it's going to be at the lumbosacral angle anyway, and probably L4. And when we get higher, if we've got a local stiffness, then to come in this side bending technique is a very efficient way anyway.
So when you were asking for the knees to be pulled up towards the head of the bed, you were
just, yes, to use the,
to pull in?
Yes.
So, like, you have to watch maybe for, like, the hip flexors to come in, because wouldn't that sort of extend the lordosis?
Yes, yeah. It's not a really big deal, that. I think it's just a matter of just trying to enact that the extensors don't work, yeah.
You think you get an effective enough block if you use the next smallest wedge down?
Oh, yeah, I think so. Yeah. No, I don't think so. I like that one myself, the bigger one better, but than the smaller one. But yeah, the other one's really good when you're mobilizing lots of peripheral joint stuff. So both are kind of good. Any questions? Let's do it and see where we go. Okay. So we've got our patient in that position that we did over the end of the bed, which is a very, very, very useful technique, especially for women working on tight men. It's a very useful technique. Now then, here's a bit of a problem. What do we do if we've got an L4-5 that is hypomobile, but the L5 is hypermobile? Because by coming through here, the chances are we are not going to be able to totally eliminate the stresses and weight from the legs and pulling down on the L5-S1 junction. So what we're going to do is this. We're going to put the legs up, and then we're going to sort of come back to the L5-S1 junction and just perhaps get a little bit of muscle action to that particular point there until we get no movement. Sorry, let me start this again. Let's take the situation where L5-S1 is tight, L4-5 is hypermobile. The other way, it's not such a difficult problem. So let me start that again. L4-5 is tight, L5... Eliminate that, David. Run that back. Okay, what we've got is an L4-5 which is hypermobile, and an L5-S1 which is hypomobile. Okay, so if we start doing this, the chances are that this is going to stretch out this 4-5 very efficiently, which is already hypermobile. So how can we do this? Well, the way to do this is this. Instead of pushing, okay, on the sacrum away from 5, which would, of course, be the standard way of stretching 5-S1. But it also puts a little bit of stress on 4-5 because we can't totally hold 5 still. The way to do it is to take hold of 5 and push it cranially into 4. Because if I do that, see, I'm going to have to take off my splint. If I do that like this, I'm pushing 4-5 into extension. And we found that it's hypermobile into flexion, so that protects it. And by taking this away from the sacrum, I'm actually producing a flexion at L5-S1. And so this is a very useful procedure to actually push up on the L5, push it cranially into 4, which protects the hypermobility at 4-5 because it takes it into a little more lordosis, but it stretches away from the sacrum, and that would fulfill the rule of protecting the hypermobile joint. So sometimes you may find that you can come in here on the lamina and actually push here and push upwards with this. It slips a little on here because it won't fix in there. So that's one way. I prefer myself to try and hook best way I can around the spinous process here. So that is a very useful technique, and I'd like you to do that because I think it's a fundamental improvement on just sort of stretching into flexion, of using the principle of moving bones cranially, which is going to be part of what we do occasionally.
How would you do it the other way around then, if it was L4-5 was hypomobile and
An L5?
L4-5 was hypomobile?
Not a great problem there. If we're dealing with this now that's hypermobile, it's much easier to sort of support this a little bit in dorsiflexion and only just come onto that one bone and just push down. That's not a great difficulty, it doesn't seem to be. It's the trouble is when this is hypermobile, it's much harder to control when this is excessively mobile and this is very, very stiff. If this is stiff, I think you can still get onto the L5 fairly well and move it away from 4, which would be stretching 4-5. Now, if we have the legs pushed up a little bit, they can hold it a little bit into that position, and you don't really produce a tremendous amount of mobility. You would have to make sure you're off the sacrum, of course, but you just come onto the L5 spinous process. So let's just do that one, and then we'll go into extension. But I want to sort of finish this by 1:45 so that Chris can make his presentation before lunch, and we'll have enough time to finish this off so that he doesn't have to do it in 2 parts, so that there's nice little compartments, and we can always put the techniques in as we go. Okay? So just try that one, which is a big...
Lois, do you want some Dr. They have no more Dr. Pepper in there?
Okay. Just to clarify, being as there was my little brainstorm there, I got the wrong description. We're talking about an L5-S1 which is tight, and we're talking about an L4-5 which is hypermobile. And what we're saying is that even under the best of circumstances, if in our standard technique, this is number 1 technique, I push down like this, it all depends upon whether I can hold that stiff enough to make sure that only the sacrum comes down and that no strain takes place over here. On the other hand, if we use the sort of situation like this, okay, where instead of pushing sacrum away from L5, we push L5 up towards L4, then the difficulty of only stabilizing this and making sure it's very efficient is actually nullified. We don't have to worry so much. So this is a principle that we're going to sort of see as we do manipulating and so on, that it is not always like the standard procedures we should be following in a kind of a slavish manner. We should be always looking to see whether in fact we can improve this. And this is one case where moving the L5 in a cranial fashion into the hypermobile joint protects the hypermobile joint, but still manages to put stretch between the sacrum and L5. So instead of moving sacrum away from L5, we move L5 away from sacrum and move L5 towards L4, thus protecting L4. And those principles we should be kind of looking for in terms of many of these particular procedures. There was another one that we just were considering with someone here, that if we are trying to have a hypermobile one, for example at L5, and this one is stiff like this, okay, is it possible just to hold that and push down there? Yes, it probably is. But what we could do, and this is relatively easy to do, is to make sure that by our contact here with the patient's legs like this on there, that we slightly push up in that direction so that we tilt the sacrum up a little bit and just support it. And one of the ways of doing this is if you've got a mobile table like this, okay, there's the table that the patient is laying on, we've got our block and we put it just slightly under the knees now instead of here. And by just letting the table drop down a little bit, and the chair of course stays at its fixed position, so it's sideways round to the patient, you'll find that this is tilted up a little bit into an increased lordosis, and that will protect this joint here. So all the time we should be looking to protect the hypermobile joints because we want our force dissipated over the tight joint. So this is the techniques that you would expect now to do when you are at this level. It's not that here's a technique, learn it, that's how you do it. Yes, sir. It's a matter of saying, look, here's a technique and this is what we're trying to achieve. Now, from your experience, how can you achieve this better? By slight modifications. I think it was Deb telling me, was it you yesterday, about the Cybex? Yes, it was Kathy, telling me that she'd worked out a series of procedures on the knee of mobilizing by using the Cybex as a stabilizing thing. This is very good. This is what we should all be doing. And it's, once you understand the principles, we can make all kinds of modifications. What you often get in some of the systems is they come out with a modification. It's like teaching a new course, you know, so you never catch up because here's another thing, another modification. But if we're encouraging everybody to say, how can we make this better for me, then you will be responsible for the modifications, so long as you understand what the principles are. And I think that's what we've done, you know, to a large extent this morning. I see people doing different things and making people work, and everybody seems to know exactly what they're doing. That's wonderful. All right, what we're going to do now is to have a presentation by Chris on some of these relationships of pain production, because of course on the whole a lot of the time it's one of the key presenting features, and we know that patients are very keen on us dealing with the pain thing, although sometimes it's a complication and we're looking much more at function with it. But the whole principle of this is really important. So what we'll do with this, so long as Chris doesn't feel that he's reached a point, let's say in about an hour, that he'd like to stop, and because there's another half an hour, but if it's like an hour and a bit, then we'll continue with Chris until he's finished, and then we'll have lunch. So it's like a package. But if you feel, Chris, that this is a convenient time to stop, and you look at your watch and you think, right, let's go to lunch now, then you just make your mind up on that. That'd be great. Okay? Okay. Thank you.
I will have 2 or 3 sessions. So we will have one now, before lunch, and then perhaps I will have another one tomorrow. And the first session will be a little bit of dry material. I mean, we must get some terminology straight. We must do something with what is left and what is right, what are pain fibers, where are they coming from, etc., etc. So we will try to do that. I will do it fast because I don't want to take any more of the valuable time of David Lamb, because what he is doing is really great, and you will see me probably more than you see David Lamb, because I'm in Portland and he is in Canada, and perhaps I will be a little bit involved in it. So my time is more flexible than his. Okay, so I will try to keep it as short as possible. What we will try to do is, what we talk about is pain, is nociception, is sensations, and of course the combination, but that will be in another time, with the tissue repair. And what I would like to do today also is explain what the selectivity of the nerve system is, how it works, where we get that from. So the bad news is that we have to skip a little bit with pages, flip around, but it is better because that at the end, tomorrow or the day after, everything will fall together, and we'll perhaps have a view how it actually is. So selectivity, and treatment options, and how we're going to approach that selectivity. Okay? Okay, a lot of this is in your handouts. Pain. Definition. Well, we all know a little bit what it is. It is unpleasant sensory and emotional experience associated with actual potential tissue damage, or describes in terms of such a damage. What important is, and we will do this really fast, essential components are perception of tissue damage and interpretation of unpleasantness. So there is some room to move there. Subjective experience, it is. Influenced by arousal, so we will come back later what actually an arousal is. Age, sex linked, I have a couple of question marks behind that. I don't want to get on thin ice here. Cultural background, level of anxiety, level of understanding, expectation and motivations. So basically what this is, it is a complete can of worms. How are we going to do this? How can we influence this? And where can we put somebody? And how are we going to call it? So if somebody has a high arousal, how are we so how are we going to call it, that if a therapist comes in with me or after me with a patient, that I can let him a note, I can write him a note and say, well, I cannot say it's a whiner. And basically, is there a whiner? That is what we're going to try to find out. The pain is not really perfect. The body is not perfect. For example, with an angina, it causes pain, arousal goes up, it becomes more painful, heart rate goes up, blood pressure goes up, patient can be dead by then. Nociception is different, as we all know. Nociception are mechanisms associated with the detection of a potential or noxious stimulus and the transmission and modulation of the resultant information. So, what happens at the spot? That is nociception. It has nothing to do with pain. Nociceptors can be mechanical, can be thermal, can be chemical. What we will do today is mainly on the chemical part. So I will try to explain what kind of chemicals will be released. And I'm not a neurologist, I'm not a physiologist, I'm a physical therapist who is trained in this system a little bit. So there will be questions that I cannot answer, and that's fine. So potassium, kalium, potassium gives a stimulation of the nociceptors. Histamine is stored in the mast cells, is released by a mechanical stimulation or a chemical stimulation. Serotonin is everywhere in the body, is all over. Then we have the plasmakinins, the bradykinin, and kallidin. And then we have two important ones. That's prostaglandins and substance P. Especially these two we will work with. If I'm going too fast, please let me know. Substance P, yeah. What I had a real difficulty with is to determine what classification of nerve fibers are. What is afferent, what is efferent, how are we going to call it? I mean, we have 1, we have 2, we have 3, we have A alpha, we have A beta. So I wrote down a little bit what I feel, what we can use. For the efferent part, we can use Erlanger and Gasser. That's pretty straightforward. With the afferent, we can use either Erlanger and Gasser with the A and the C, or we can use Lloyd and Hunt, who is 1A, 1B, 2, 3A, 3B, and 4. In this course, if I talk about 4 fibers, I mean afferents. I mean this. If I talk about 3B, then I'm talking about the fast pain. If I'm talking about the 3A, I'm talking about mechanos, fibers. Okay, so look it over, and if you can do anything with it, then that would be great.
The 3s, you're talking mechanoreceptors?
I will come back to that. I will explain it. What? Yes, for the afferent. Yes. So the 3B is the fast pain, 4 is the slow pain. And then we have the 2 and the 3A. That's mechanostimulation. If we talk about sensations, then we can say sensation is dependent on structure. So if we have a nerve pain, that is sharp, bright, and burning. And most of the time it runs in the distribution of a specific nerve. Bone pain is a deep, boring, and very localized pain, most of the times. Am I going?
Well, we're trying to find the pages that
Okay.
Yeah? C5? Okay. What?
Bingo, yeah.
Bingo. Vascular pain is a diffuse aching and poorly localized and may be referred to other parts of the body. We all know how to do this. Muscle pain, and we have visceral pain. So the sensation you feel is dependent on the structure. So a tendon pain is different than a vascular pain. Pain receptors. We can say that we have the unimodals, so they respond to one input, so mechanical, thermal or chemical, and we have the polymodals. And the polymodals are most of the times are the C ones, who will travel through the 4 fibers. Some of them are 3, but I wouldn't be too concerned about that. If we're talking about chemical pain, then a couple of items is important. The prostaglandin. Please remember that if you have an injury somewhere, or there is nociception somewhere, everything works together. One item cannot work without the other one. So it is one big operation. Important for us is the prostaglandin, E2. This will give an increase of the sensitivity of the 3-4 endings. Vasodilatation, increase of the permeability overall. It has a decrease of noradrenaline, and it gives a stimulation of the mast cell. Then the mast cell is combined with histamine, as we all know. The substance P, substance P is a material that is basically everywhere in the body. In some locations we have more substance P than in other locations. With our nerve endings, they are in fasciculi. When there is nociception, then a fasciculus will burst open and substance P will be released at the site. And it will give a local vasodilatation, so it will open up. It will increase the permeability. So what will happen is H2O and protein will go into the interstitium, with result that the interstitium will be cleaned, initiate the release of prostaglandin, so the two work together. It gives a diapedesis, outflux of leukocytes from the blood capillaries through the attracting force of substance P. Proliferation induction, fibroblast, angioblast. So nociception works together with tissue repair. Increase of the sensitivity of the 3B nerve endings. What this means is that the defense mechanism is in place. So the fast twitches of pain if you injure yourself, and after that you touch it again, then we're talking about the 3B. With the aching pain, that's the 4 pain. So these two are vascular, and the rest of it is cellular.